In the last clip, we divided um, clinical conditions into two basic types, the ones that involved a change in cognition that we could call a psychotic episode, where there is some hallucination or delusion that's very powerful, and an equally powerful but different kind of change, where the person makes some kind of a mistaken evaluation of the circumstances and sees everything as leading to depression or mania or some other of the many forms of therapy where there is still contact with reality, but the person's having a great deal of difficulty executing normal function. And here we need to talk about therapies, because the job of the therapist is to get that person back to more nearly normal function so that they can live in society. And we're going to divide therapies into two great groups, those that involve behavior, including talking, and those that involve biological things. And there is a tendency to try to deal with the psychotic episodes, at least first, with biologicals, because they seem not to be able to be talked to. So in terms of behavior therapies, there are a bunch of different types of talking therapies. The textbook talks about psychoanalysis, client-centered therapy, and other forms that involve a verbal interchange using words as the behavior. There are still other behavior therapies which involve talking, but the focus is really on, let's say, classical conditioning, where you might use desensitization to get a person who is afraid of, let's say, snakes to eventually realize that there is nothing to be afraid of with at least certain snakes, or operant conditioning. Now, we haven't yet read the chapters on learning. That's partly because I chose to put the things in this order, but we will come back to this, and this will be a powerful therapy. Another kind of behavioral therapy, at least in my classification, is cognitive, which involves thought processes. And here we might have someone be taught, as we discussed a bit in the last video, that their approach to characterizing things in the world is distorted. It really isn't that bad. There's lots of cognitive distortions in mental illness. One of the most powerful ones is the body image distortion in anorexia nervosa, where the patients look at themselves in the mirror and see themselves as very fat, but when they look at a picture of someone who's not them, they're much more accurate in judging the body image. And finally, in the text, it talks about group therapy, which fits perfectly with the first part of the class, where we talked about the mind and consciousness, first in individuals and then in a group situation as part of the social psychology chapter. So the groups can be very powerful and can help people to do talking therapy in a way that an individual therapist might not be able to, no matter how skilled that person is. So all of that is over here, and that's the important talking therapy, which is what many of us get if you go to a clinic. Over here, on the other side, we have the biological therapies. The most important one, most ubiquitous one, in some people's minds the most troubling one, is the rapid prescription of drugs. Drugs can be very effective. They can relieve the depression symptoms. They can calm down the anxiety. But they also is a classic American strategy. If I've got something wrong with me, go to the doctor and he or she will give me a pill and that will fix it. Quick fix. There are other forms of biological therapies that we'll discuss again in lecture. Electroconvulsive shock is one of them. Neurosurgery, which has a troubling history, especially in the United States. There's a whole history that's worth reading about lobotomies, where we use those to control the crazy behavior of patients, often psychotics, in mental institutions and try to get them out of the institutions. But the question has to be asked, at what cost to the patient? And since these neurosurgery techniques are not reversible, these costs were permanent. But there are other forms of neurosurgery that might be coming that are more attractive. One of them is putting in a brain pacemaker. Now, people are familiar with cardiac pacemakers, and some of this is used in neuroscience, but perhaps after we understand clinical psychology well enough from a brain perspective, we could put a brain pacemaker in and stimulate a region of the brain, maybe contingent on when the patient needed it. Maybe you get a little bit blue and you push a button, and then you feel a little better because of the brain pacemaker. One of the most interesting ones that has my attention is goes back to the fMRI machine and uses classic techniques of biofeedback. And so I want to show you a quick clip of a brain area that seems to be involved in pain and can be biofeedback manipulated under the right circumstances by the patient themselves in an fMRI machine to reduce their pain perception. Here we have a biofeedback picture of where activation changes were effective in producing pain relief. And you see right here the anterior cingulate cortex, the rostral portion, lit up in this paper, which I will provide in lecture. So if we could manipulate a person's pain perception by getting them to alter their brain reaction through biofeedback techniques in an fMRI machine, and especially if that has some enduring consequence, so it doesn't just stop when you get out of the machine, then one could imagine that you could also do this in other ways. For example, suppose you were anxious and we knew what brain area or areas were activated. Could we not give you an fMRI machine exercise to teach you to not react by using biofeedback techniques? Now, I don't want to continue to push biofeedback. I was more interested in having you think expansively about what might be possible in the future. But we will spend a little time in lecture talking about biofeedbacks. The classic example in my lifetime came more in the 70s when they had these alpha wave detecting machines, and you were supposed to put this band on your head and then sit in front of the machine, and it would light up whenever you made an alpha wave, and then the goal was to try to produce more alpha waves, and this was supposed to be maybe some shortcut to the kinds of things that you got by meditating. So I think there's a bright future in combining neuroscience with classical therapy that we might want to look at going forward. But there's also much work to be done right now, and we'll take this on in lecture where we talk about all the various types of conditions, starting with the DSM-5 categorization, things in the text, and looking at all the various types of therapies that have been applied to try to treat those conditions. And just know that this is an enormous area of human endeavor, one that is very important to our productivity as a species, and perhaps even more important, very important to our happiness, not only for the patients themselves, but for their families and caregivers.